is the Director of Regulatory Products for Wolters Kluwer Law and Business. Darcy manages an electronic portfolio that includes healthcare compliance, coding and reimbursement, life sciences, research grants management, human resources, and corporate counsel content. She also co-manages the risk assessment questionnaires for ComplyTrack, Wolters Kluwer's enterprise governance, risk and compliance management solution. Darcy is an attorney and has been with the company for over 10 years. Our next guest speaker is Lynn Reinheimer, who many of you may already know. Lynn is the manager of ComplyTrack editors and sales engineers for the healthcare compliance and reimbursement team here at Wolters Kluwer. In this role, Lynn co-manages the compliance content in ComplyTrack, manages the sales engineer team, leads software demonstrations, and assists in client training and methodology. Lynn is a lawyer and consultant and has been with the ComplyTrack since its inception, and I'll turn the presentation over to them.
Great. Thank you, Kelly. This is Lynn. And as we get started, I just want to go through our agenda for our call today, and then I'm going to pass it over to Darcy to get started. But Darcy and I, in our role co-managing the risk assessment content in our Risk Assessment Manager, have been working with the work plan for over a decade now, interpreting it, drafting risk assessment question sets for it. And what we're going to be doing today is taking you through basically our research, what we've done in developing these question sets based off of focusing on the new project areas within the work plan, specifically for Medicare Parts A and B, focusing on hospitals, other providers and suppliers. We'll talk a little bit about hospice, home health, and nursing facilities. There are also a few revised project areas in the work plan that we're going to be addressing today as well. We've got information in our slides related to project areas that aren't necessarily new, but there have been some changes in the last year as far as the regulations that speak to them or new reports that might have come out. So that's addressed within our slides. Then at the end, we're going to do a really brief demonstration of our Risk Assessment Manager, leaving time at the end for questions. So if you have questions, you can use the menu bar to submit those to us, and we'll get to as many of them at the end of the webinar today as we can. So at this point, I'm going to turn it over to Darcy.
Thank you, Lynn. The Office of the Inspector General, or the OIG, is responsible for protecting the integrity of the Department of Health and Human Services. To that end, and as a result of its audits, investigations, and other activities, it releases a number of reports and other documents each year. One of the most important documents the OIG releases is its annual work plan. The work plan provides the provider community with a description of the areas of focus for the OIG in the coming year. We call these project areas. Each of the project areas in the work plan is made up of a short paragraph describing the primary objectives. If you look at the top portion of the project area, you can ascertain whether the project area is new, as is the case in our example, whether the project area is revised, which it would state, or whether it is simply carried over from a prior work plan with no changes, in which case there is no text at the start of the paragraph. In the body of the paragraph, the OIG usually refers to some legal or regulatory authorities relevant to the subject matter of the project area. You should pay particular attention to those, as the OIG is telling you where to look for the rules on the subject. If you look at the end of the paragraph, you will see some letters and numbers. These are the internal identification codes the OIG has assigned to the project area. This one says OAS, which tells us it will be a report from the Office of Audit Services. We also see a date indicating the year in which the OIG expects to release the report, here 2016. Now that we have a handle on the basic information provided in each project area, let's dig into some of those newly added Part A and Part B project areas, starting with the project area for hospitals on medical device credits for replaced medical devices. In this project area, the OIG is going to examine whether payment amounts for replaced medical devices were appropriate. Let's start with a fundamental principle laid out in the Provider Reimbursement Manual, that of the prudent buyer. That principle says that a prudent and cost-conscious buyer not only refuses to pay more than the going price for an item or service, he or she also seeks to economize by minimizing cost. The manual then indicates that one way of minimizing costs is to obtain free replacements or reduced charges under warranties for medical devices. The manual states that any alert and conscious buyer seeks these advantages, and CMS expects that Medicare providers of services will seek them as well. Although there are slight differences in the language of the respective CFRs for inpatient and outpatient, the general rule for replaced medical devices is the same. There is a payment adjustment or reduction when one of the following occurs. The device is replaced without cost to the provider receives full credit for the cost of a replaced device, or the provider receives a credit equal to 50% or more of the cost of the new device. These rules apply to certain APCs and to certain DRGs, so you should monitor the annual updates to the OPPS and IPPS payment systems that are published in the Federal Register each year to ensure that you are always working with the most current list of APCs and DRGs that fall under the policy. When billing on these claims, be sure to use value code FD, that's Foxtrot Delta, which is a credit received from the manufacturer for a medical device. When value code FD is used, you must also use one of three condition codes, 49, 50, or 53. Condition code 49 is for replacement of a product earlier than the anticipated life cycle due to an indication that the product is not functioning properly. Condition code 50 is for when the manufacturer or the FDA has identified the product for recall and therefore replacement. Condition code 53 is for outpatient claims that have received a device credit upon the initial medical device placement in a clinical trial or a free sample. Coming full circle back to the prudent buyer principle, I want to go over an example that's provided in the manual. Provider B purchases cardiac pacemakers to replace malfunctioning equipment. Provider B does not ask the supplier or manufacturer for full or partial credits or for payments available under the terms of the warranty covering the replaced equipment. The credits or payments that could have been obtained by Provider B must be reflected as a reduction on the Medicare bill. This example places a clear obligation on providers to reduce claims where they could have obtained a credit but did not. This obligation is also echoed in OIG reports. So ensure you're getting any credits due and adjusting or reducing bills appropriately. Medicare payments during the MSDRG payment window. This is also known as the 3-day payment window. And before we jump into discussing the rule, I want to note two things for you. First, this rule applies to hospitals paid under the Inpatient Prospective Payment System, or IPPS. Second, there is an analogous 1-day payment window rule for certain other providers, like long-term care or inpatient rehab, but I will not be addressing that rule separately. The DRG payment window rule defines when outpatient services are not paid separately, but rather are considered to be included in the inpatient lump sum or DRG payment. Here is the statement of the rule, and it's long, so bear with me. Pre-admission services otherwise payable under Medicare Part B are included in the lump sum payment if those pre-admission services are furnished to a beneficiary on the date of the beneficiary's admission to the hospital and during the 3 calendar days immediately preceding the date of the admission to the hospital if the services are furnished by the hospital or by an entity wholly owned or operated by the hospital, and one of the following. The services are diagnostic, or the services are non-diagnostic services and the hospital does not attest that such services are unrelated to the beneficiary's inpatient admission. Breaking this down, let's start with the first requirement related to settings subject to the MSDRG payment window. 3 types of settings are subject to the window: admitting hospitals themselves, settings that are wholly owned by admitting hospitals, and settings that are wholly operated by admitting hospitals. An entity is wholly owned by the hospital if the hospital is the sole owner of the entity. An example of this setting is an outpatient clinic that is wholly owned by a hospital. An entity is wholly operated by a hospital if the hospital has exclusive responsibility for conducting and overseeing the entity's routine operations, regardless of whether the hospital also has policymaking authority over the entity. An example of this type of setting is a hospital-operated physician office. Diagnostic and non-diagnostic services. CMS considers all diagnostic services performed within 3 days of an admission to be related to the admission. This is and has been the rule for a long time. In the last few years, the changes to the DRG payment window have been focused on non-diagnostic services, specifically broadening the scope beyond requiring an exact coding match between the outpatient services and the inpatient admission. CMS now considers all non-diagnostic services performed within 3 days of an inpatient admission to be related to the admission, unless the hospital indicates on the claim via attestation that the service is unrelated. To be considered unrelated, the non-diagnostic services must be clinically distinct or independent from the reason for the beneficiary's inpatient admission, regardless of whether the inpatient and outpatient diagnoses are the same. This is the key to non-diagnostic services not being included in the MSDRG payment window, and they must be documented in the medical record.
CMS validation of hospital-submitted quality reporting data. Under this project area, OIG will be determining the extent CMS validated inpatient quality reporting data. The Hospital Inpatient Quality Reporting Program, or Hospital IQR program, was authorized by Section 501B of the Medicare Prescription Drug Improvement and Modernization Act of 2003. Section 501B authorizes CMS to pay hospitals that successfully report designated quality measures a higher annual update to their payment rates. Under the fiscal year 2016 inpatient prospective payment system, hospitals that do not successfully participate in the Hospital IQR program and do not submit the required quality data are subject to a 1/4 reduction of the market basket update. CMS then makes data collected under the Hospital IQR program available to the public on Hospital Compare. In July 2015, CMS released its Hospital IQR program fiscal year 2017 reference checklist for calendar year 2015 discharges. To participate in the Hospital IQR program, the hospital must first register on qualitynet.org, QualityNet being the only CMS-approved website for secure healthcare quality data exchange. The hospital must then identify and register a QualityNet security administrator with the recommendation that the hospital also designate a second administrator to serve as a backup. Newly reporting hospitals must then complete a notice of participation, and once the notice of participation is submitted, the hospital will remain an active Hospital IQR program participant until a withdrawal is submitted. The next steps on the checklist are related to data submission. The hospital must submit quarterly data for hospital consumer assessment of healthcare providers and systems survey data, aggregate population and sample size counts, clinical process of care measures, healthcare-associated infection measures, and perinatal care elective delivery measure data. On an annual basis, the hospital must complete structural measures information and must sign and complete the data accuracy and completeness acknowledgement. This is an acknowledgement by the hospital that the data submitted is accurate and complete to the best of its knowledge. CMS performs both random and targeted provider selection of hospitals participating in the program on an annual basis. To meet the validation requirements, selected hospitals must receive a confidence interval of 75% or greater based on the combined chart audit validations for the applicable 4 quarters. Hospitals must submit the requested patient charts to CMS or its contractor within 30 days of the date identified on the written request. This CMS validation is what OIG will be reviewing as part of this project area. You can find the data submission deadlines applicable for the current Hospital IQR program year on the Hospital IQR program Important Dates and Deadlines of the Quality Reporting Center website. Physician home visits, reasonableness of services. The focus of this project area is on Medicare payments to physicians for E&M home visits. Physician home visits are making a comeback, but maybe a little differently than we may remember them. Instead of stopping by the patient's house with their stethoscope and their medical bag, physicians today may be using greater technology and equipment on these visits, portable x-rays or EKGs, for example. This discussion requires a quick differentiation between physician visits to a care facility, such as assisted living facilities, group homes, or custodial care facilities, and visits to a private residence. When furnishing E&M services for domiciliary care visits to residents residing in a facility that provides room, board, and other personal assistance services, CPT codes 99321 through 99333 must be used. When furnishing E&M services to patients residing in their own private residence, CPT codes 99341 through 99350 must be used. As discussed by CMS as part of its Independence at Home demonstration, there are benefits to home-based primary care, including an ability for providers to spend more time with their patients, with additional focus on timely care that can improve the overall quality of care and can lower healthcare costs while potentially lowering the need for care in institutional settings. The Independence at Home demonstration is a 5-year study ending September 30th, 2017, where chronically ill Medicare beneficiaries are provided with primary care services in the home setting. In June 2015, initial results were announced that Medicare had saved more than $25 million in year 1 of the study. There are a number of requirements for billing for home visits. Physicians must be present in the home to bill for a home visit. In 2012, for example, a physician in Michigan was arrested on a variety of counts, including that he billed Medicare for home visits, even though records showed he was out of the country at the time. Unlike with home health care, the beneficiary does not need to be confined to the home. The medical record must document the medical necessity of the home visit in lieu of an office or outpatient visit. Coding for home visits is based largely on the time spent face-to-face with the patient and/or their family. For a home visit with a new patient, codes range from 99341, which is typically 20 minutes of face-to-face time, up to 99345, which requires 75 minutes. For established patients, code 99347 is typically 15 minutes of face-to-face time, up to 99350, which requires 60 minutes. Recently, in October 2015, a CEO for a company that works with physicians to provide home visits to patients across multiple states pled guilty for an upcoding scheme. He required that physicians use only the highest 2 codes regardless of the time spent on the home visit. And if a physician chose a lower code, he would often have the code changed. To help ensure compliance, you can begin by making sure you have developed and implemented policies and procedures addressing the selection of the appropriate CPT code, establishing that home visits must be medically reasonable and necessary and not for the physician's or patient's convenience, and preventing providers from soliciting home visits. Ensure that travel time and related expenses are not included when determining CPT code. Monitor to ensure home visits are of equal quality and frequency as an office visit. And you should also monitor your local coverage determinations for guidance on coverage and billing for physician home visits. Histocompatibility laboratories, supplier compliance with payment requirements. The OIG's focus with this project area is related to costs claimed by histocompatibility labs on their cost reports. Histocompatibility labs perform testing required for bone marrow and organ transplantation. Histocompatibility tests are covered under Medicare when used in preparation for a kidney transplant, bone marrow transplantation, and blood platelet transfusions when reasonable and necessary for the patient. It is also covered for, forgive the pronunciation, ankylosing spondylitis, which is a form of spinal arthritis, when other methods of diagnosis would not be appropriate or have yielded inconclusive results. Monitoring should be conducted to ensure that when histocompatibility testing is conducted for ankylosing spondylitis, there is adequate documentation from the physician to support the medical necessity of the test. It's always nice in the work plan when the OIG in a project area includes specific citations or direct references to review, and Darcy showed some of that in the beginning. Not every project area is like that, but this one is. In the project area, the OIG specifically references 42 CFR 413.9 and 42 CFR 413.24 as it focuses on cost reports. From March 31st, 2013 through September 30th, 2014, histocompatibility labs reported $131 million in reimbursable costs on their most recent cost reports. 42 CFR 413.9 addresses costs related to patient care and establishes that costs claimed on the cost report must be related to the care of the beneficiaries and include all necessary and proper costs incurred in furnishing the services. Under the principles of reasonable cost reimbursement, necessary and proper costs are those costs that are appropriate and helpful in developing and maintaining the operation of patient care facilities and activities, and are usually costs that are common and accepted occurrences in the field of the provider's activity. 413.9C3 establishes that the reasonable cost of services must be based on cost related to the care of Medicare beneficiaries. Reasonable costs include all necessary and proper expenses incurred in furnishing services, including administrative costs, maintenance costs, and premium payments for employee health and pension plans. If the provider's operating costs include amounts not related to patient care, specifically not reimbursable under the program, or flowing from the provision of luxury items or services, these amounts will not be allowable. Under 42 CFR 413.24, the histocompatibility lab must provide adequate cost data, which must be capable of verification by qualified auditors and must be based on an approved method of cost finding and on the accrual basis of accounting. The cost data must be accurate and in sufficient detail to accomplish the purposes for which it is intended. And additionally, 42 CFR 413.200 contains requirements specific to freestanding histocompatibility labs and also independent organ procurement organizations. Under this section, histocompatibility lab cost reports must provide a complete accounting of the costs incurred by the lab in providing covered services, the total number of Medicare beneficiaries who receive those services, and any other data necessary to enable the contractor to make a determination of the reasonable cost of covered services provided to Medicare beneficiaries.
Prolonged services, reasonableness of services. In this project area, the OIG is going to be looking at the use of prolonged physician services evaluation and management codes. There are 4 prolonged physician services E&M codes, 2 that are used in the office or other outpatient setting, and 2 that are used in the inpatient setting. The 2 initial E&M codes, 99354 and 99356, are used for direct face-to-face patient contact that requires 1 hour beyond the usual service for the companion E&M code, that is billed on the same day by the same physician as the companion E&M code. No more than 1 unit of codes 99354 and 99356 is acceptable. After that, you use the other 2 prolonged services codes 99355 and 99357 for each additional 30 minutes following the first hour of prolonged services. Let's talk about each of these requirements a bit. Face-to-face contact. Physicians may count only the duration of the direct face-to-face contact between the physician and the patient beyond the typical or average time of the visit code billed. What cannot be billed as face-to-face time? In the case of prolonged office services, time spent by the office staff with the patient cannot be billed, and the time the patient remains unaccompanied in the office cannot be billed. In the case of prolonged hospital services, time spent reviewing charts, discussing a patient with house medical staff, or waiting for test results or the use of facilities cannot be billed. 1 hour beyond the usual service. The time for usual service here is referring to the typical or average time units associated with the companion E&M code as noted in that code. There are lists in the manual section on prolonged services of all the companion E&M codes and their respective typical times and the corresponding thresholds you must meet in order to bill for prolonged services. But the key here is that if the total duration does not equal or exceed the threshold time, the physician may not bill for prolonged services. Billed on the same day by the same physician as the companion E&M code. This requirement is pretty straightforward, but it does raise the issue of making sure things are properly documented in the medical record. The medical record should contain information about the duration and content of the medically necessary E&M service and prolonged services billed. It must show that the physician personally furnished the direct face-to-face time with the patient specified in the code definition. It should also include the start and end times of the visit and the date of service. Many of the MACs have issued documents with particular instructions, so you should look for those to see if there are additional requirements in your area. In closing on the subject, I note that the OIG states in the project area that the medical necessity of prolonged services is rare and unusual, and you should consider it so as well. Anesthesia services. For anesthesia, there are two project areas in the work plan. The project area that carried over is on payments for personally performed services and modifier use. This one, for non-covered services, is new and very discrete. The OIG is going to examine whether there was a related service that was reasonable and necessary and therefore appropriate for payment. The general payment rule for anesthesia services is based on allowable base and time units multiplied by an anesthesia conversion factor specific to the locality. There are different payment rates depending on the type of service rendered. They include payment at the personally performed rate, payment at the medically directed rate, and payment at the medically supervised rate. Payment at the personally performed rate. This applies when the physician performs the entire anesthesia service alone, in a teaching capacity, or with a certified registered nurse anesthetist or an anesthesiology assistant. No separate payment may be made for the assistant unless it is determined to be medically necessary for both the physician and the assistant to be involved. In such a case, documentation must be submitted by both to support payment for the full fee for each of the two providers. Payment at the medically directed rate. Medicare pays for the medical direction of up to 4 concurrent procedures if the physician does several things for each of the procedures. The required items are listed on the slide, and they must be documented in the medical record. A physician who is concurrently directing the administration of anesthesia to not more than 4 surgical patients cannot ordinarily be involved in furnishing additional services to other patients. But addressing an emergency of short duration in the immediate area, administering an epidural to ease labor pain, or periodic rather than continuous monitoring of an obstetrical patient does not substantially diminish the scope of control exercised by the physician in directing the administration of the anesthesia to the surgical patients. Further, while directing concurrent anesthesia procedures, a physician may receive patients entering the operating suite for the next surgery, check on or discharge patients in the recovery room, or handle scheduling matters without affecting payment at the medically directed rate. However, if the physician leaves the immediate area of the operating suite for other than short durations, or devotes extensive time to an emergency case, or is otherwise not available to respond to the immediate needs of the surgical patients, the physician's services to the surgical patients are supervisory in nature, and payment will not be made under the medically directed rate. Last, I want to flag for you some very specific limitations around anesthesia services that are noted in the CMS National Coverage Determinations Manual in 2 areas: cataract surgery and transvenous cardiac pacemaker surgery. You should examine those NCDs.
Physicians referring, ordering Medicare services and supplies. Section 6405 of the Affordable Care Act requires physicians and other eligible non-physician practitioners to enroll in the Medicare program to order or refer items or services for Medicare beneficiaries. OIG will be reviewing Medicare services, supplies, and DME referred or ordered by physicians and non-physician practitioners to ensure the payments were made in accordance with Medicare requirements. As highlighted in its December 2015 fact sheet on Medicare enrollment guidelines for ordering referring providers, CMS establishes that Medicare Part B claims use the term, quote unquote, ordering referring provider to denote the person who ordered, referred, or certified an item or service reported in that claim. Only physicians and certain types of non-physician practitioners are eligible to order or refer items or services for Medicare beneficiaries. This list includes physicians and the following non-physician practitioners: physician assistants, clinical nurse specialists, nurse practitioners, clinical psychologists, interns, residents, and fellows, certified nurse midwives, and clinical social workers. There are 3 requirements to be able to refer or order items or services. First, the provider must have an individual national provider identifier, or NPI. That NPI must be a type 1 individual NPI and not a type 2 organization NPI. Only type 1 NPIs are allowed by Medicare for ordering or referring items or services. The second requirement is that the individual must be enrolled in Medicare in an approved or opt-out status. Physicians and non-physician practitioners who wish to opt out must file a written affidavit with Medicare in which they agree to opt out of Medicare and meet certain other criteria. Valid opt-out affidavits signed on or after June 16, 2015 will now automatically renew every 2 years. And the third requirement is that the individual must be eligible to order or refer. For interns or residents, claims for items or services that they order or refer must include the name and NPI of a teaching physician. State licensed residents may enroll to order or refer and may be listed on claims. As part of the Phase 2 denial edits, MACs will deny claims from clinical laboratories for ordered tests, claims from imaging centers for ordered imaging procedures, claims from suppliers of durable medical equipment, prosthetics, orthotics, and supplies for ordered DME POS, and claims from Part A home health agencies if the claims lack a valid individual NPI. Those physicians or eligible non-physician practitioners who enroll in Medicare as ordering referring providers only may not seek or receive Medicare reimbursement for services they furnish and do not have billing privileges for submitting claims to Medicare directly for services provided to beneficiaries. Additionally, I want to also make mention of a new March 1st, 2016 proposed rule addressing program integrity enhancements to the provider enrollment process. A few major elements of the proposed enhancements if finalized. CMS could revoke enrollment if the provider has a pattern or practice of ordering, certifying, referring, or prescribing Part A or B services, items, or drugs that is abusive, represents a threat to the health and safety of beneficiaries, or otherwise fails to meet Medicare requirements. CMS would be able to deny or revoke a provider's Medicare enrollment if it determines that the provider is currently revoked under a different name, numerical identifier, or business identity. And perhaps the largest provision, it would require providers to report affiliations with entities and individuals that, firstly, currently have uncollected debt to Medicare, Medicaid, or CHIP. Second, have been or are subject to a payment suspension under a federal health care program or subject to an OIG exclusion. Or third, have had their Medicare, Medicaid, or CHIP enrollment denied or revoked. CMS could deny or revoke the provider's Medicare, Medicaid, or CHIP enrollment if it determines the affiliation poses an undue risk of fraud, waste, or abuse. So I would encourage you to take a look at that new proposed rule. Ambulatory surgical centers, quality oversight. Of all the project areas Darcy and I are speaking on today, this is the only one that we do not actually address in our risk assessment manager solution. And the reason for that is this project area is directed specifically at CMS and not at the providers. Under this project area, the OIG will be reviewing Medicare's oversight of ambulatory surgical centers. ASCs must be certified by state agencies or accredited to participate in the Medicare program, with the majority of ASCs choosing to be certified by state agencies. The Medicare conditions of coverage provide the basis for quality oversight and contain minimum health and safety requirements that ASCs must meet to be eligible for Medicare reimbursement. The conditions can be found at 42 CFR Part 416 with the interpretive guidelines located at Appendix L of the State Operations Manual. In February 2002, the OIG issued a series of reports addressing quality oversight of ASCs. As identified in these reports, there are a number of factors that require adequate quality oversight of ASCs, including the growth of ASCs, as well as the rise in the scope and complexity of the procedures performed within them. Findings demonstrated that Medicare's oversight was not adequate. The OIG found and referenced in the work plan project area that nearly 1/3 of ASCs certified by state agencies had not been recertified in 5 or more years. These recertifications are necessary to ensure that the ASCs continue to meet the minimum standards for health and safety. Additionally, the OIG found that in regard to complaint surveys, ASCs were frequently left unmonitored without a resurvey or requirement for them to resolve their deficiencies. It was determined that CMS was doing little to hold state certification agencies and accreditors accountable to the Medicare program and to the public. Recommendations from these reports included updating the conditions of coverage to include patient rights and continuous quality improvement. And since the release of those reports, both of those conditions were added to the conditions of coverage. Other recommendations included that CMS hold state agencies and accreditors fully accountable to the Medicare program and to the public for their performance overseeing ASCs. While this project area is focused on CMS and not the ASCs themselves, it is important for ASCs to continue to conduct quality-focused risk assessments, using the conditions of coverage as an area of focus. And as you'll see toward the end of this webinar, this type of conditions of coverage assessment can be conducted through our risk assessment manager. Skilled nursing facility prospective payment system requirements. The focus of this project area is documentation. The OIG looking at documentation in support of the claims paid by Medicare with a specific emphasis on therapy payments. Documentation requirements are specified in 42 CFR 483.20. In the language of the project area, OIG specifically mentions 3 of the documentation requirements. Documentation must include a physician order at the time of admission for the resident's immediate care, a comprehensive assessment, and a comprehensive plan of care prepared by an interdisciplinary team that includes the attending physician, a registered nurse, and other appropriate staff. Additional requirements include, but aren't limited to, assessing residents using the quarterly review instrument at least once every 3 months, maintaining all resident assessments completed in the previous 15 months in the resident's active record, and using those results to develop, review, and revise the resident's plan of care, and ensuring that the resident has a discharge summary when the SNF anticipates discharge. As the OIG mentions in the project area, there have been a number of OIG audits, investigations, and inspections in this area. A few reports of note to mention. In November 2012, OIG issued a report entitled Inappropriate Payments to Skilled Nursing Facilities Cost Medicare More Than $1 billion in 2009. OIG found in this review that SNFs billed almost 1/4 of claims in error in 2009, resulting in $1.5 billion in inappropriate payments. A large cause of these errors was in coding therapy. SNFs billing for ultra-high therapy rugs when they should have billed for lower levels of therapy or non-therapy rugs. Additionally, there were a number of cases identified where reviewers found that the amount of therapy indicated in the beneficiary's medical records was not reasonable and necessary. There were also instances where there were no physician orders for the services provided. OIG came out with 2 new reports in 2015. In June, OIG released the report entitled Skilled Nursing Facility Billing for Changes in Therapy, Improvements Are Needed. And in September, it released the Medicare payment system for skilled nursing facilities needs to be reevaluated. In the latter study, OIG found that payments for therapy greatly exceeded SNFs' costs for therapy, and that SNFs increasingly billed for the highest level of therapy, even though key beneficiary characteristics remain largely the same. OIG recommended in this report, among other things, that CMS change the method for paying for therapy and strengthen oversight of SNF billing. There have also been a number of settlements related to claims for rehabilitation therapy. In 2014, a SNF chain settled for $3.75 million. In 2015, another SNF chain settled for $3.5 million. Both cases related to allegations of fraudulent billing for medically unnecessary therapy. What steps can nursing facilities take? Audit. Audit to ensure the amount of therapy indicated in the beneficiary's medical records was reasonable and necessary. Monitor to ensure the SNF does not routinely provide the minimum number of therapy minutes required to bill for the higher levels of therapy. Develop policies and procedures that prohibit presumptively placing patients in the highest reimbursement level unless it is shown that the patient could not tolerate that amount of therapy, rather than using individualized evaluations to determine the most suitable level of care for the patient's clinical needs. Develop policies and procedures requiring the SNF to report only the actual time spent providing therapy to patients and not report estimated or rounded minutes, and not count the time required to perform the initial evaluation, and develop the treatment goals and plan of treatment as minutes of therapy, either in the medical record or on the MDS. Each of these were included in the allegations for the two settlement agreements I mentioned a moment ago.
Now let's talk about the two areas that were revised in the 2016 work plan, starting with Medicare oversight of provider-based status. And forgive me if I speed up a bit through this and the next project area, but there's a lot of information I want to get you in the time that we have. Provider-based status. Previously, this project area focused exclusively on whether provider-based facilities met CMS criteria. In the revised project area, the OIG indicates that it is going to look at the number of provider-based facilities that hospitals own, CMS methods to oversee provider-based billing, and any challenges with the attestation review process. So there are some additional things OIG will examine, but the focus for providers should be on ensuring you meet the regulatory criteria if you claim the status, and have attested to the same if you sought a determination. I will discuss, pardon me, I will discuss some of the requirements, but probably the single most important takeaway is that a facility or organization is not entitled to be treated as provider-based simply because it or the main provider believe it is provider-based. It must meet the regulatory requirements. And if the provider wants to know for certain that they have the status, they must submit an attestation stating that the facility meets the regulatory criteria. And if a hospital, a joint venture, or an off-campus facility, the provider must make some additional attestations and/or meet some additional requirements. Documentation of the basis for the attestation must be maintained so that it can be provided to CMS if requested. Any facility or organization for which provider-based status is sought, whether located on or off the campus of the main provider, must meet certain requirements related to licensure, clinical services, financial integration, and public awareness. For licensure, the facility or the organization seeking provider-based status and the main provider must be operated under the same license unless state law requires something else. Clinical services. The clinical services of the facility or organization seeking provider-based status and the main provider must be integrated. An example of such integration would be for the professional staff of the facility or organization claiming the status having clinical privileges at the main provider. There's a comprehensive list in the CFR of evidence in support of this requirement. Financial integration. The financial operations of the facility or organization must be fully integrated within the financial system of the main provider. This is evidenced by shared income and expenses between the provider and the facility or organization. Public awareness. The facility or organization seeking provider-based status must be held out to the public and other payers as part of the main provider. When patients enter the provider-based facility or organization, they should be aware that they are entering the main provider and should be billed accordingly. Now for a couple of billing and coding requirements. First, ensure that for professional services, claims include the appropriate place of service code. Second, ensure proper use of the PO modifier, which was required effective January 1st, 2016. Now let's turn to the other revised project area, Hospice General Inpatient Care. The revision here expanded the scope of the project area. The OIG added language about medical necessity, plan of care requirements, and payment requirements. I'm going to highlight some of the more important points, but have listed the relevant CFR part on the slide so that you can dig in more deeply on your own. Now, what are the core requirements for hospice care? Written certification of terminal illness. Second, a statement electing hospice care. Third, a comprehensive assessment of the patient. And last, a written plan of care. Let's start with certification of terminal illness. You must have the certification on file before submitting a claim for payment. The requirements for certifications can be found at 42 CFR 418.22. Election of hospice care. The beneficiary must make an election of hospice care, and that statement must contain some very specific information and acknowledgments. The OIG specifically noted in this project area that they are going to look at the contents of election statements. So you should be monitoring yours to make sure they include all the necessary information. Comprehensive assessment of the patient. The comprehensive assessment must identify the physical, psychosocial, emotional, and spiritual needs related to the terminal illness that must be addressed in order to promote the hospice patient's well-being, comfort, and dignity throughout the dying process. The comprehensive assessment must take into consideration several factors, all of which are listed in the CFR. Written plan of care. The hospice must develop an individualized written plan of care for each patient. It must include all services necessary for the palliation and management of the terminal illness and related conditions, including things like interventions to manage pain and symptoms and frequency of services. Now, let's address the inpatient care portion of the project area. There are two types of inpatient care that can be rendered to a hospice patient: respite care and general inpatient care. Respite care is short-term inpatient care provided to the individual only when necessary to relieve the family members or other persons caring for the individual. Contrast that with general inpatient care, which is provided in an inpatient facility for pain control or acute or chronic symptom management, which cannot be managed in other settings. Examples of appropriate general inpatient care include a patient in need of medication adjustment, observation, or some other stabilizing treatment. It is not appropriate to bill Medicare for general inpatient care days for situations where the individual's caregiver support has broken down, unless the coverage requirements for the general inpatient level of care are otherwise met. The next three slides highlight a point or two for the project areas that carried over into the 2016 work plan with no changes. We will not be discussing them, but we wanted to provide you with some of the newer resources in those project areas. Instead, I'm going to turn it over to my colleague Lynn Reinheimer for her demonstration of our ComplyTrack solution.
Thank you, Darcy. And I'm only going to take about 5 minutes to highlight our Risk Assessment Manager and how you can use it to address everything that we've been talking about for the last 50 minutes. And then there'll be a few minutes left at the end for questions. So if you do have questions, you're welcome to submit them. If we don't get to them all today, and we probably won't, we'll get answers together and we'll send them out to you following the webinar. But what I have up on the screen is our Risk Assessment Manager, and this is the piece of ComplyTrack that Darcy and I co-manage the content for. And what we're doing with the Risk Assessment Manager is we're providing organizations with pre-developed question sets that you can utilize to do your own internal risk assessment. And the questions are all developed by a team of attorneys. And the most popular library of content that we have within the system is our OIG Work Plan library, largely because of everything we showed you today. Every year when the work plan comes out, and now it looks like mid-year updates to the work plan come out, there are a wide variety of new project areas that organizations need to be aware of, need to understand the requirements for, and need to ensure that you're in compliance with. So we're doing the research, we're developing the questions for you to be able to utilize to do your own risk assessment with our content. And we do focus specifically on the Medicare Parts A and B requirements for hospitals, home health, hospice, nursing facilities, other providers and suppliers. And for the first time with the 2016 plan, we also included project areas related to managed care. So if any of your organizations have a managed care component, we're accounting for that within the system as well. If I come into the hospital subset, you're now seeing the project areas from the 2016 plan that we've developed question sets for, both new areas as well as areas that were in previous work plans that have carried forward, that we've reviewed and updated as regulations and reports and guidances and these source documents require. I want to open one of them up as an example. I'm going to come into one that Darcy was talking about regarding provider-based status, because I want to highlight a really important feature in the system, and that is if you see after each question in the question set, there's a citation link. So we're not just giving you the questions that we've developed, we're also showing you where those questions were taken from. So if someone's answering this assessment and they come to a question and they don't understand why we asked it, or they want to read more about it, or they're curious what speaks to it, you can click on the citation link and be able to see. In this case, it comes from 42 CFR 413.65B3I. And I can click on this, and it's going to take me right into the document and to the specific section of the document that we're citing to. So you're always able to see where the questions came from, and it provides a nice educational component, because I can tell you, researching these project areas, it's a process. It takes days. It's a lot of sources and reviews. So we're doing that research, we're drafting the questions, we're tying the questions back to those source documents for you to have access to and to be able to review. So OIG Work Plan is easily most popular library of the content, library of risk assessment manager from a content perspective that we have, but it's not the only library. So just for your reference, we have a conditions of participation library. I reference the conditions of coverage for ambulatory surgical centers in that piece of the webinar. We have conditions of participation assessments also for hospitals, community mental health centers, critical access hospitals, home health, hospice, long-term care. These conditions often find their way into the work plan project areas. They're often cited, referenced, areas that you should be looking at, giving you an assessment that you can work with that is going to allow you to focus not just on the conditions, but also on the accompanying survey or guidelines. We have assessments related to the HIPAA requirements, privacy, security, and breach. You can do HIPAA assessments. We have what we call our comprehensive library, which is addressing higher risk topical areas like anti-kickback and STARK, different patient safety and environmental safety areas, departments like patient accounting and finance and emergency department that you can work with. And there are other libraries as well. For the sake of time, I won't go into, but it's a ton of content that we're providing you with across different entity types, not just hospital content, across different entity types that you can work with. And when you go through and you complete an assessment, having the ability to generate reports, you can generate action plan reports where you can see, based on how questions are being answered, what you need to be focusing on as an organization. You can generate enterprise reporting that's going to allow you to compare facilities against each other. You can do a wide variety of custom reporting, both text as well as chart reports. So if you're presenting to the board and they need to understand for the areas that you're assessing where you're doing well, where you're not doing as well, where there's been improvement, which is often something very difficult to put a finger on, that we have reports that are going to allow you to demonstrate that. So that's just my 5-minute overview on our risk assessment manager. At this point, what I'm going to do now is turn it back over to Kelly and see if there are some questions that we can answer before we come to our end time. And this is just a slide right now that shows you how you can access the work plan.
Great. Thank you very much, Lynn, and thank you, Darcy and Lynn, for your presentation. We do have quite a few questions in the queue. We have about 5 minutes left, so we're going to try and get to 2 or 3 of them. I would like to thank those who took the time to submit them, and as Lynn referenced, we will be getting back to you after the webinar in regards to your answers. First question we have, and it's coming from Fran, and she's asking, you mentioned OIG reports on the medical device credit issue. Are there any specific devices mentioned in those reports?
I'll take that one, Kelly. This is Darcy. Yes, there are cardiac devices. I know pacemakers, cardioverter defibrillators, and their associated leads have all been mentioned in reports on the subject.
Great. Thanks, Darcy. Next question is from Sue, and she's asking, can you please discuss in a little more detail your process for developing the work plan questions in the assessment tool that you just showed us, Lynn?
Sure. So the day the work plan comes out, we start analyzing the work plan, seeing what's new, what's carried over. For the things that have carried over, have there been any language changes? And then we pride ourselves on a really quick turnaround. So from the day the work plan comes out to when we're done with the hospital-related project areas, it's about 4 weeks. Then it's about another 4 weeks for hospitals, hospice, home health, nursing facilities, other providers and suppliers. We then make those available to our clients, and then another handful of weeks for the managed care content. So it's a very, very quick turnaround from the day the work plan comes out to when you receive it. We're looking specifically and putting these together at, has the OIG issued reports in these areas? Do the regulations or CMS manuals speak to this? Are there FAQs or other documents that agencies have come out with? Learn Matter articles that we can look to. And we draft the questions, and as you saw, tie the questions back to those source documents. And then the next year, when the new work plan comes out, we start again with fresh eyes. So if something carried over, we're still looking at it as if it was new as far as our research and how we're putting those questions together.
Great. Thank you, Lynn. We've got a very good question here from Tom, and Tom's asking, will CMS make determinations on whether an entity is wholly owned?
Thanks, Kelly. Okay, so in regards to the MSDRG payment window, we talked about settings subject to the MSDRG window, and I think that is in this context. So the answer is no. CMS has indicated that, because of the multitude of possible relationships, business and financial, that may exist between a hospital and a physician practice or some other Part B type of entity, it's not really feasible. They did provide several examples in the calendar year 2012 physician fee schedule final rule, and for your edification, that citation is 76 FR 73285.
Great, thanks. And we have a couple minutes just for one last question. This is coming from George, and he's asking, what is the citation for the proposed rule that was mentioned regarding Medicare enrollment?
Right, and again, the date for that was March 1st, 2016 that it came out, and I believe, don't hold me to it if I'm wrong, that the Federal Register citation for that is 81 FR 10719. 81 FR 10719, but again, it's the March 1st proposed rule.
Great, thanks, Lynn. Well, we're right at the top of the hour. Once again, I would like to thank everyone for joining us today. I hope you have a great rest of the day, as this concludes our presentation on the 2016 OIG Work Plan.